Welcome to this explainer. Today, we're diving into a really captivating clinical mystery, rebuilding our understanding of aortic regurgitation right from the absolute first principles. I'm super excited to guide you through this because honestly, the mechanics of this disease are just fascinating. We're going to look at how the heart operates, how it adapts to a literally massive mechanical burden, and crucially, how it can sometimes completely hide its own failure. Let's get right into it.
Okay, so picture this. A young guy comes in for a standard, routine pre-employment medical. You pump up the blood pressure cuff, wait for the reading, and it comes back at a completely astonishing 150/40. No way, right? So you reach down to feel his wrist, and he's got this intense bounding pulse that just rapidly collapses the very second you let go of his arm.
And this guy? He is the walking embodiment of the paradox we're solving today. Because how in the world can someone with such dramatic physical signs, like a bounding, collapsing pulse and a head that literally nods gently with his own heartbeat, feel absolutely fine? Because he does. He tells you he feels perfectly normal. Well, that right there is the trap. You see, by the time the specific valve lesion actually makes someone feel unwell, the ventricle underneath it has often already been silently and progressively damaged for years. So what's actually happening mechanically inside his chest?
To figure that out, we have to start by defining the core lesion aortic regurgitation. At its most basic, this is just a failure of the aortic valve to seal shut during diastole, the heart's resting and filling phase. Normally, once the left ventricle ejects blood forward into the aorta, that valve snaps tightly shut. It's supposed to hold the line. But in aortic regurgitation, or AR, the valve leaks. Blood flows straight backward from the high-pressure aorta right back into the left ventricle throughout the entire diastolic phase.
Now, this one single failure creates a really massive physiological problem. During the resting phase of every single heartbeat, the left ventricle suddenly has to juggle two sources of inflow at the exact same time. First, it gets the normal inflow arriving from the left atrium, but second, it's getting hit with that abnormal regurgitant backflow pouring in from the aorta. So the left ventricle is forced to handle a double diastolic volume load every single heartbeat for the rest of the patient's life, or at least until the valve is fixed. And literally everything about how this disease presents stems directly from this exact mechanical burden.
What's really interesting is that mechanistically, these leaks originate from two totally distinct families. On one hand, you have valve leaflet disease. Basically, the doors themselves are broken. Think of a bicuspid aortic valve in a younger patient, or maybe infective endocarditis eating away the tissue, or a rheumatic disease scarring it up. But on the other hand, we have aortic root disease. And this is an area that's honestly often underweighted in clinical practice. The aortic root is like the door frame that the leaflets need so they can meet and close properly. If that root dilates, say from long-standing hypertension or a connective tissue disorder like Marfan syndrome, it physically pulls otherwise healthy normal leaflets apart. The doors are perfectly fine, but the door frame is stretched out.
So faced with this constant, unrelenting extra volume pouring in from two different directions, the heart executes an absolutely brilliant adaptation: eccentric hypertrophy. It physically remodels itself by adding sarcomeres in series. This allows the chamber to dilate and enlarge, which means it can now accommodate and pump a massive total stroke volume without letting the internal filling pressures just skyrocket. It's a spectacular structural change that lets the heart keep up, and as we'll see shortly, it directly sets the stage for some very strict clinical guidelines.
But the absolutely crucial point here is that this massive forward stroke volume, combined with the continuous diastolic backward leakage, creates a drastically widened pulse pressure. Since the ventricle is now ejecting its normal forward volume plus the extra regurgitant volume it just cut, the systolic pressure shoots way up. But then diastolic pressure completely plummets because all that blood isn't being held in reserve in the arterial system. It's just continuously leaking right back into the ventricle. That huge gap between the high systolic and the low diastolic, that's your widened pulse pressure. And this one mechanical fact unlocks the entire physical exam.
You know how medical textbooks love to torture us with those long lists of eponymous signs, like Alfred de Musset's famous head bobbing? Well, you can completely forget rote memorization here. You really don't need flashcards for any of these if you just understand the physics. Every single one of these classic signs is simply a different anatomical location where you're detecting that exact same widened arterial pressure wave. Whether you're feeling the bounding water hammer pulse at the wrist, seeing Corrigan's sign in the carotids or Quincke's sign in the nail beds, or hearing the sounds over the femoral artery, you're just feeling or seeing a rapidly rising and then rapidly collapsing column of blood. It's the exact same physiological signature, just caught in different parts of the body.
And this exact same mechanical physics explains the classic auscultatory finding you'll hear through your stethoscope: a high-pitched, early diastolic decrescendo murmur. Now, it's high-pitched because it's driven by a massive, swift pressure gradient forcefully pushing blood from the aorta back into the ventricle. And it's decrescendo, meaning it gets quieter and quieter, because that pressure gradient naturally falls as the pressures between the two chambers gradually equalize over the course of diastole.
But here is the dark side of this incredible physiological adaptation, and really the main narrative pivot point for this explainer. The heart is almost too good at adapting. The compensation itself actually becomes the danger.
We call this the compensation trap, because eccentric hypertrophy does such a good job of hiding the underlying disease by keeping internal pressures manageable. Patients with severe chronic AR can feel totally normal for years. Our young guy with the nodding head feels fine simply because his heart has stretched out to handle the load. But falling into this trap means the ventricle is silently and progressively accumulating irreversible volume overload damage. By the time those subjective symptoms, like exertional dyspnea, fatigue, or angina, finally show up, the compensatory capacity of that ventricle is completely exhausted. Real, irreversible myocardial damage has often already happened, and unfortunately, it doesn't always bounce back even if you do fix the valve.
So how on earth do we escape this trap? Well, we use echocardiography as our early warning system. We absolutely cannot just wait around for the patient to feel sick. Echo has three really critical jobs here. First, confirm the diagnosis and the mechanism. Is it the leaflets or the root? Second, quantify the severity of the leak. And third, and definitely most importantly, track the left ventricle size and function serially over time. We're actively looking for subtle, specific structural thresholds that tip us off that the heart is starting to fail, long before the patient ever even notices a thing.
Which brings us directly to the latest 2025 ESC/EACTS guidelines. Instead of waiting for symptoms, we now have very precise, logical structural triggers to intervene in completely asymptomatic patients. If the indexed left ventricular end systolic dimension crosses 22 millimeters per square meter, or the indexed end systolic volume exceeds 45, or if the ejection fraction drops to 55% or below, we act. These aren't just random numbers, they are early, highly sensitive alarms, signaling that the ventricle is losing its reserve. The guidelines put these exact triggers in place precisely because we now know that waiting for subjective symptoms is just way too dangerous.
Furthermore, this 2025 guidance introduces a massive and really fascinating shift to our management toolkit. The transcatheter era has officially reached aortic regurgitation. There is now a new Class 2B recommendation for transcatheter aortic valve implantation, or TAVI, expanding this technology's role right into AR for selected patients. Specifically, this is for symptomatic patients who are ineligible for conventional surgery but have the right anatomy for it. Historically, AR has been super tough for transcatheter valves because there often isn't any firm calcification to actually anchor the new device against. So, this recommendation reflects a growing, genuine confidence in dedicated device platforms and our ability to treat this leak in a much less invasive way.
Now let's contrast this slow, silent, chronic trap we've been talking about with acute, severe regurgitation. Imagine a sudden aortic dissection flap that acutely tears the valve support apart. This is a full-blown surgical emergency, not some scheduled decision based on echo trends over time. In acute AR, the ventricle has absolutely zero time to compensate. It hasn't had years to undergo that brilliant eccentric hypertrophy. So this massive volume rapidly hits a small, stiff chamber, causing a severe, abrupt pressure spike that forces the patient into rapid pulmonary edema and cardiogenic shock. It is a wildly different, immediate physiological crisis compared to the chronic form.
So the next time you feel a collapsing pulse or see a gently nodding head, try to look beyond the surface of the sign. Don't just name the eponymous physical finding, trace it all the way back. Think of that leaking valve, the compensating ventricle, the widened pulse pressure, and most importantly, ask yourself, what is the clock quietly running on before the compensation becomes the disease itself? Just how much longer can this heart's silent compensation truly be trusted? Thanks for joining me on this explainer today. I'll see you next time.